we'll talk about no. So just when we get to treatment, we'll talk about mobilizing. So you can do your unilateral and central PAs for treatment, and also so you can come in here and do some PAs. You're springing. You can also do a little at the end where you just a little quick thrust. These you probably don't get much of a cavitation with, just because we're springing ribs and things. There's not a lot of joint there. So, and then where you get your individual rib with little molds, and a little quick thrust there to kind of get your manip. Sometimes I just call it sudden thrust mobilization more than anything. You're really not going for cavitation. Just giving it a quick little jolt. Sometimes that's enough to free it up.
Well, I put it right back in. It's out of place.
Can, yeah, I've seen people with real hypomobile ribs due to hypomobile thoracic spine. So if you're treating that, always treat the thoracic spine first, then go to ribs. A lot of times you're thoracic, you treat the thoracic spine, the ribs get better without having to treat the ribs.
Why would that be? We talked about it, light anatomy, you talked about anatomy. Where's the head of the rib attached? To a transverse process, and where does the head of the rib go into the body? Remember the demifacets? It attaches to one segment. It'll attach the first 10 ribs attached to one vertebrae, so you can actually get a segment. And about, I think, Charlie, maybe 80% of the time you treat the segment and it takes care of the rib dysfunction. Something like so. So you always treat that first. But that's because of the anatomy. It's a straight anatomy.
Does it matter if the rib's out of place either posterior or anterior? Because I've seen people with like
We'll treat them a little differently, yes. But for the springing part, not as much. So we're still going to treat the thoracic spine, whether it's anterior or posterior. We're going to treat the thoracic spine the same.
Yeah. The other thing I wanted to mention was I've had in acute settings, what I've had happen to me is trauma. People come in with multiple trauma and they've had pelvis fracture and they had an emergency room. They're worried about a head injury, and a week later they're telling you to go walk them and they start complaining about rib pain, which totally got away from everybody. So it's not uncommon at all for you to find a rib fracture in a place that maybe has level 1 trauma. A lot of trauma admits. It's not at all uncommon because you're the first person to really kind of make them move in a week or so.
Yeah, and after those chest tubes, after they remove the chest tube, a lot of people don't get that breathing, that motion back. They've had that tube in there, so things don't function very well. You got the tube sticking in between your ribs. You're probably not going to move those ribs very well. It hurts. So really look at those patients after they take the chest tube out and they've healed a little bit. You can start then assessing mobility, but give that incision time to heal a little bit before you start.
And a lot of people assess. We haven't spent not quite as much time on assessing breathing. I'm not sure if you would probably do in other classes, but that's a big part of these patients. Sometimes it's their diaphragm, sometimes it's other things. So.
All right, so let's work on rib springing.